Good afternoon, my name is Sarah Richards and I'm here to talk to you about pilonidal cysts. It's personally one of my favorite topics because I have been affected by this very painful disease. So, just a quick overview about what we're going to talk about today. First, we're going to discuss introduction. What is a pilonidal cyst? Misconceptions about this disease, the pathology of it, frequently asked questions for people who are affected by it and those who may be curious, acute treatment for problems that aren't necessarily too bad, and then chronic treatment for problems that are much more advanced, partial closure method, the Cardiacus and Limburg methods of treating the cyst, prevention, and acknowledgements. So the first misconception about pilonidal cysts is the term called Jeep disease. It was assumed that in the World War II era that over 70,000 soldiers were affected by pilonidal cysts, not because of, random happenings and how it's actually attained. They believed that it was from the long rides from being on Jeeps. They thought that the pressure from hitting the Jeeps for long hours traveling to and from the trenches would be the cause of the cyst. And so over 70,000 soldiers were affected by it and hospital bound for weeks during World War II. The pathology. The term pilonidal cyst comes from the term pilo and nidal, which both means hair nest. So it is believed that the hair follicle of the natal cleft in the sacrococcygeal region is responsible for the reason why this infection occurs. There's many different causes. One, of course, is pressure. That's from the constant touching the tailbone. Ingrown hairs, another reason too. But not all of these infections are from ingrown hairs. Some just happen from a natural body response. Whenever your body tends to think that there's an infection going on, it builds up with a lot of pus, and which applies a lot of pressure to the region. And many surgeons and physicians aren't really sure if the condition is congenital or if it's acquired through, your daily actions and through obesity, etc. But for the most part, it's pretty random and no one can really predict when it happens. It can also reoccur. So it can actually, the pilonidal cyst doesn't have to be in the tailbone region. It can be in the groin, the interdigital web, meaning your fingers and your toes, and in your occipital region, so in your head. And the picture here is showing what a pilonidal cyst looks from the outside. There's just slight little holes here, little ducts to drain it, and that can happen naturally or through surgery in order to drain it. And then the fluid builds up behind the surface of the skin and before the tailbone, and all this fluid occurs. And then an excision would be removing either the skin or cutting into the skin in order to drain the fluids. And as you can see, because there's a lot of fluid near the tailbone, which is a very sensitive area, it's a very, very painful condition. So frequently asked questions, most people want to know who can get it. Anyone can actually get it, and it's mostly young adult men who get it of working age because of the pressure that they constantly apply on their tailbone. A physician told me that basically it's one of those things that you wish never happens to you, just like mono. So it's basically one of those random things, and you deal with it once you have to. Is there anything you can do? There are at-home remedies where you can just basically soak in a tub of warm water and hope that it goes away. Some cysts, but because of the way they're created, there's a small little duct that allows some of the drainage to go outside of the skin by itself, which allows it to drain naturally. But unfortunately, that is messy for obvious reasons. You will have probably pus and blood remains, in your undergarments. So that's not necessarily an ideal situation, but it's better than undergoing minor and major surgeries. Another treatment is acute, so necessarily not as invasive, but it is still painful from my own experience. And chronic treatment, which is much more painful and requires anesthesia. And some of the symptoms is pain in the coccygeal region, which is, right by your tailbone and your spine region, right by your sacrum. And redness, swelling, fever, of course, because your body is thinking that it's fighting a bacterial infection. Pus drainage, if it does that because it has a natural duct in it, or increased white blood cells in blood, and oftentimes surgeons and physicians will have blood samples drawn to see if there is an increase in white blood cells. But that's not a really common method of evaluating the situation. It's usually pretty obvious when the patient has pains in that region. And also, another method of which people deal with this painful disease is compensating for the pain. So oftentimes there's people who won't wear certain kind of jeans because they put pressure on the area. I know personally, sometimes I can't sit directly on my tailbone, even though I have had surgery to deal with it. It still is it can reoccur, and it's still, the area is not the same as before. I know some people won't even stand on the rails near the elevator because of the pain that it applies to the area. So it's a pretty, not necessarily life-changing, but it does alter the way you interface with things that touch that area. So acute case treatment, and this is also the method that I have in order to treat my situation. It's minimally invasive, and it just involves a small incision right in the area where the pilonidal cyst is, and sometimes, as you can see from this instance, the area isn't necessarily swollen, and it can be hard for people who have this disease to know that they have it because it's not necessarily something that's obvious, and it's in a difficult place to see. Often a doctor with, of course, experience and knowledge would be able to identify what the symptoms are just because the patient complains about it. Treatment of this situation involves local anesthesia, which is a bit painful because the needle that is used for anesthesia is very, sharp, and it does hurt. And already in an area that's very sensitive from the cyst. So the needle goes into the cyst, and it is quite painful. And from personal experience, I believe the local anesthesia didn't really affect much of the pain. And ideally, after the doctor incises the small cyst, they apply more pressure onto the already very sensitive area, and in order to drain the pus and the blood. And also the smell, the doctor says, is not very for the weak-hearted. So it's a very interesting procedure that is for those who are only brave-hearted. There are fast recovery options with the acute case treatment. There's options with the packaging with the gauze, and the gauze is very thin and it's medicated, and the doctor packages the incision in order to allow the sides of it to close up before the top so that it doesn't create like a little balloon that can be refilled. Bandaging, where they just put a bandage over it, they give you maybe Vicodin to deal with the pain, and they recommend not necessarily incorporating too much movement. Sewing, which are many different methods that are a bit painful as well, and partial closure so that it can still drain itself so that the cyst is less likely to reoccur. And there's minimal to no scarring, so this is why this is ideal, because it doesn't involve too much of a cosmetic disposition. It's not very well seen either. Chronic case treatment, I apologize for the pictures, it is a bit more graphic, but a chronic case treatment involves removing the entire sinus tract, not just an incision. So it's an excision, and it involves entire anesthesia, so the patient is not awake during the procedure. It is definitely more invasive and a bit more painful, I'd imagine, of course, with the help of anesthesia. And there's many different ways that this can be treated. One is the Limburg flap, and the one is cardiacus flap. And it's a low recurrence rate because the entire tract is removed. And a doctor told me to imagine it as basically you have a balloon that's filled up with pus and cysts, and that's basically what the cyst is. And incision only cuts the balloon open to drain it. But if you remove the entire balloon, which is what the chronic case treatment of an excision is, it cannot refill. So another complication with chronic cases is hypertrichosis, which is people who have excessive hair growth, which can complicate the surgery because there's more hair surrounding it. and sometimes doctors will find like 30 strands of hair tucked away in a chronic case of pilonidal cyst disease. So here's a partial closure method, and it's a little difficult to see, but this is the tailbone, and of course this is the area right above it, the spine, tailbone, and then here's the cut where the excision has been done, where the cyst is removed. And they'll take a special needle that's curved and sew it together so that not all of it is closed. So see, the final result here is there's still a little opening so that it can still drain itself out. And this, again, is for the chronic treatment. It's not for the acute cases. And then the Cardiacus and Limburg methods. So above 1A and 1B right here are the Cardiacus method. And that is when basically there's just an incision that's opened. Actually, excuse me, it's an excision, not an incision. And the entire cyst is removed and then sewn up accordingly. And then the Limburg method, which is when it's a bit smaller, a bit bigger of an opening, and it has a flap. And the doctors sew it up that way. But the Cardiacus method isn't as ideal. The Limburg method isn't as ideal because of the fact that it is a bit more obvious for cosmetic reasons. Someone wouldn't necessarily want to have this. And then prevention. Good hygiene is definitely a good way, but it's not a guarantee to prevent it. Losing weight if obese, again, more pressure on that area will increase the likeliness of it happening, but again, no guarantee. And avoiding prolonged sitting and pressure on this region. And again, it is very random, so there's not necessarily a cause and a cure for the disease. It's just a matter of dealing with it once it occurs. And I would personally like to thank Loyola Marymount University, the Frank R. Seaver College of Science and Engineering, my Professor Bonilla, Caitlin Jennings, and my teacher's assistant, Tony Tavish. Thank you.